recording now.
We're recording now, so. Watch you guys.
He just stares at us all the time. I'd love for him to come in because we're gonna be talking about some of his slides, so that's. He goes all the time, like just in random classes, I'll turn back and he'll just be staring at us, and I'm like, okay.
You know what? It's like, it's not. Yeah.
Exactly.
Yeah.
Okay, so we're gonna get started. Again, it's just us, so if you guys have any questions, like just stop us. But we're gonna be doing some cases. Again, we have a heart failure Kahoot at the end, but like I wanted to go over specifically some more of the conceptual things with anticoagulation. I know a big component of it is dosing, and that's something where, I mean, we could put the graphs up here in the tables with the dosing, but a lot of it is just memorizing those key things. So we kind of felt doing more conceptual things would be more helpful for you guys for today. So again, we kind of have this balancing game when we're talking about blood coagulation, right? So obviously, if you have too much blood clotting that's going on, that's what's putting you at risk for these major conditions that we talk about in CVS 1, like DVT, pulmonary embolism, and then stroke, which you'll talk a little bit more about in CVS 2. But remember, it's this balancing component to it. So we're not just like using medications that are going to completely get rid of this process, because you're often going to need like specific, you're often going to need a little bit in terms of like injury, right? And we're going to talk about that when we go over like our natural anticoagulation factors, right? A lot of the times we want to make sure that that's limited to areas of injury when we actually need it. So if I get, you know, a cut or something, that I'm actually able to form, you know, the platelet plug, the fibrin mesh that's needed so that I'm able to heal. So making sure that it's actually balancing. What's going on? Sorry, but I'm just going to keep talking. But making sure that everything is kind of balanced there. So there's kind of like three main components that you guys, I think, talked about in terms of promoting blood coagulation. So does anybody have like one that they remember they want to go over? Stasis, is that what you said? Yeah, so the first one is like blood flow dysregulation. So you have stasis, which is one of the main contributors towards like our red thrombosis, right? So you have your venous thrombosis, which is your red thrombosis, and then your arterial thrombosis, which is your white thrombosis. And we know that there's differences between the two of them. When we talk about just clots in general, they're not all the same, right? And as part of that, we also have your turbulent flow, right? So when you're kind of categorizing these in your mind, I often like to think of like turbulent flow and endothelial damage, which is our second one, kind of grouping them together in a way. And that's often because these are our ones that are going to be more like arterial based, where if you have like an actual blood vessel, right? And let's say you have somebody with ASCVD, right? And they have plaque buildup. That's going to cause like a blockage within that vessel. So when you have normal, you know, blood cells that are going through that vessel, it's not just gonna be a straight like laminar path through the actual vessel. It's gonna start hitting, it's gonna start bouncing around, you're gonna have that movement, and then that's going to contribute a lot to these clots that are forming in those cases. So you can kind of group those two together because just like conceptually thinking about, well, those often occur in our like an arterial thrombosis point of view, if that makes sense. Are there any questions there before I move on? Okay. Then the third one, so again, kind of are factors that play into that, right? Smoking is a risk factor. So in terms of patient cases, you're still looking for some of the risk factors that we talked about with hypertension, right? Things that can initiate that initial endothelial damage that can occur, right? Those are still going to be risk factors in this case for, you know, DVTs and all of those thrombotic factors. Thank you. And then the last one was hypercoagulability. So And that's just like that heightened state, which can be based on different things, right? It can be based on genetics. It can be based on different malignancies. So there's different things that we know that can promote blood coagulation overall. This is just kind of a little review separating the two different types of thrombosis. So again, knowing that there are different components, I remember this being on our test at least, like knowing the different components of each, like a venous thrombosis is mostly composed of fibrin and those red blood cells, and then arterial we mostly see is composed of platelets. And I kind of have it listed here, but our venous thrombosis is the one that we're going to be at an increased risk for like emboli. That's the one that we're going to be concerned with it detaching and moving and causing issues in other places in the body. Which we're going to talk about, like kind of different manifestations of that. Meanwhile, if it's arterial, we mostly see that it's attached to that arterial wall. We don't really see detachment as often in those types. So again, this is just kind of summarizing the name of those three that we talked about. So again, stasis, the vessel wall injury, and the hypercoagulability, just so you have those listed. That was our answer to the three on the previous slide. So we talked about main complications of the DVT. What's the main one that's kind of listed on the slide that we think is super important that we want to prevent that you guys talked about?
Edema?
What did you say?
Edema? Or just?
Edema is like a manifestation of it.
Pulmonary.
Yeah.
Pulmonary embolism.
Yeah, pulmonary embolism. So do you guys know kind of how that happens? Like why are we concerned about pulmonary embolism?
Because it
travels.
Yeah.
Yeah. So it's traveling. It's gonna go right into that right atrium, right ventricle. So it's dislodged, it goes into normal circulation, and now it's within the heart. And then from the ventricles, we know it goes to the lungs. But the lungs, those capillaries are so small. So we're not really going to see it going like towards the rest of the body from the other side of the heart, because it's just going to get stuck and get clogged there. And that's why this is like so life threatening, right? Because that can cut off blood supply and that can cause a lot of issues. That's overall what we want to prevent with a lot of our treatments. I have on here a true or false question. So anticoagulants are used to treat DVT by physically breaking up and destroying the venous thrombosis or clot. Is that true or false? And everyone's saying false. Why?
Because it just prevents it from, it's useless prevention, not actually breaking through.
Did you guys talk about what class of drugs do? I'm trying to remember. Yes. Yeah. Nice.
I think you guys get more of that in the CVS too.
I think they, yeah, I think just like, it was just like.
Oh, it's split it. I doubt that they're gonna ask you all this.
Yeah, they won't ask.
Yeah. But again, looking for those symptoms, right? If you have somebody, especially if it's like asymmetric in nature, right? That means that it's kind of like affecting one side. If you see that redness and swelling, and like you said, Haley, like edema. So that's something that we're definitely seeing with DVT. So in a case, if we see somebody that's presenting with all of these things, we can kind of use that as like a differential diagnosis to see what's actually going on.
Yeah, like Emma said, like, so, like, when you get a case on the exam, you wanna go back to that, so like, that's the stuff that you're gonna look for, like, oh, hey, this person has a DVT, right? So it's gonna be unilateral, it's not gonna be on both sides, it's gonna happen on one side. And you're gonna see, oh, the leg is red, there's swelling and stuff like that, so that's how you're gonna identify that there's like the DVT.
Let's talk a little bit about this beautiful coagulation cascade that I know I really enjoyed this part, so I'm sure that you guys do. Does anybody want to like just take a minute? You guys can write it down and like match the common names to the factors. I know he just like loves to throw these
This
out there.
will be a matching in your exam.
Oh, awesome.
Yes.
And then a brave soul to maybe share what they think, even if they want to share like a couple of them. I won't make you do all of them, but if you're confident about one.
I love you guys.
I think I actually got this.
I love it, so I'm gonna like Katie.
I love it. I love
If you don't,
it.
you have 2 more days to study.
That's chill.
Bless it.
Is tissue factor 3?
Yeah.
Thank God.
So then I think
got
I got
very-
this. So factor 1 is fibrin. Factor 1A is fibrinogen. Factor 2 is thrombin. Factor 2A is prothrombin.
Well, I think I heard you say like factor 1A is fibrin, factor
Okay.
1 is fibrinogen. How I
So
always,
it goes like 1 to
One
2A.
activated,
Okay.
yeah, one
Yeah.
exact.
the A needs activated, I always think of it, the longer word is the one that you kind of start with. Like, it, honestly, this like helps when you're on an exam and you've got like so much in your mind. Like, factor 1 is fibrinogen, and then we have that's cleaved, right, by all these serine proteases, and then you go to the smaller one, which is fibrin. If that helps you, that helped me.
Also, that is one.
So we kind of have, this is like the simplified version that he gave you of the pathway. I didn't want to copy and paste the entire big one that he puts on your slides. But remember, we have two different pathways, right? So there's your extrinsic pathway. And this one, we're going to be mostly concerned about when you're starting like the whole coagulation process. It's kind of like initiating it, right? So if we're trying to regulate coagulation, we can either target that extrinsic pathway and prevent coagulation from starting at its source, or we can target the intrinsic pathway, right? And this is where we're really concerned about that re-amplification, especially when you get to thrombin, as you kind of see like here in the middle, that's where you have it's really sustained. And that's why we're like mostly concerned about this, because it can kind of reactivate and it just keeps going. And I know that Dr. Hong in his slide, he put a whole bunch of arrows going like this. So that's what he needs. Like when you're getting to that point, it's just kind of resustaining itself and it keeps going through the process. So one way that we can specifically target the intrinsic pathway is by making sure that we're keeping any type of coagulation localized to that injury site. And I know he kind of talked to you a little bit about like natural anticoagulants, right? So things like thrombomodulin, right? When we talk about thrombomodulin, if thrombin kind of escapes and goes outside of that injury site, that's where it acts and it says, okay, I'm going to inhibit this now. We also know that there's other things that thrombin does. Does anybody remember there's like a certain, it's called protein something, and there's like two letters that are kind of associated with it. It's protein blank and blank.
CNS.
CNS, yeah. And that's something that also like thrombin is going to kind of like activate, and then that is that's kind of like breaking up those different factors as well. So you have those two different components that stem from thrombin alone. Additionally, I think he talked about heparin, right, and how heparin will bind to antithrombin 3. And then through that, he really likes to focus like on the binding of that one, how I believe it's like a covalent bond between those two that's causing that action. So keep that in mind, specifically for heparin. And then also things like vasodilation, right? So any of your prostaglandins, nitric oxide, those things that are vasodilatory in nature, we can't forget those as well. Oh, and there's one more, there's the tissue factor pathway inhibitors. Those are also the natural ones that we talk about too, and that's mostly focusing now on the extrinsic pathway, right? Because that's where we mostly talk about the extrinsic. That's where we mostly talk about tissue factor. I know I kind of just threw like a lot of that at you. Does anybody need me to like go back and like explain one of those specifically, or do you guys have like a specific question about one of them?
I'm more just curious, right, the extrinsic pathway and the intrinsic pathway, do they meet at like factor XA?
Yes.
Factor 10, okay, and then that becomes common pathway?
Yep. Yep.
That was really
Yeah.
question. Okay.
Okay. Anything else? You guys can stop me if you need. Warfarin inhibits vitamin K dependent clotting factors. Do you guys remember which ones they are?
2, 7, 9, 10 CNS.
Yep. And you put CNS in there. I was gonna do that as like a follow-up. Okay, cool. Awesome. Awesome. Okay.
All right, yeah, so now for warfarin, right, so when we come to using warfarin, there's this thing that's called INR, right, this is our target. So with the different conditions, there's different targets for their INR. So I believe anytime there's like a transplant or something like that, like a hip replacement or a knee replacement, that's when you're gonna have your highest INR. And then there's different levels for like, AFib and some other conditions as well. So that's just something that's like in your notes, you just have to go back and, like, I can put them up here, but it's not really gonna do anything for you guys, because you just have to go back in your notes. Find that. All right, so this is what we are, this is our target, right? So usually our target is between 2 and 3, and you don't want your INR to go too low, you don't want your INR to go too high. So if your INR goes too low, you're more likely to clot, right? So if a patient has an INR of 1, it's not good, because they're more likely to get an embolism. If your INR is too high, you have a higher bleeding risk, right? So let me explain this to patients, right? You want to make sure that you're at higher risk of bleeding, not that, oh, you're gonna bleed out. Right, so it's how you explain to the patient. So when you're on warfarin, there's things that must stay consistent, right? There's 2 things. You guys know what those 2 things are. Diet.
Like the leafy green.
Very good, yeah. So your diet, so your vitamin K consumption, which is found in our leafy greens, and there's one more thing. It's pretty much important for every single medication.
Adherence.
Adherence, very good. Yep, so those are our 2 things, our diet and adherence. So when we counsel our patient, especially when they're initiating, we want to tell them that, hey, like if you eat a salad every day, keep eating that salad every day, or else we're gonna have to adjust your medication. Don't go from like not eating any salads or leafy greens or whatever to having leafy greens constantly, because then it's gonna affect your INR. So if you have a patient and they start eating more leafy greens, which way is the INR gonna go? I need words.
Isn't it high? It cause high or low?
When you're like increasing vitamin K, right?
You're gonna be increasing vitamin K.
It's gonna lower.
Good, right? So you're gonna go closer towards 1, so you're gonna be at higher risk of clotting.
Something to kind of remember for this one, kind of vitamin K and like effectiveness of warfarin are moving in opposite directions, right?
Oh,
So
yeah, because they're at war, yeah.
yeah.
Now I
So if
know.
I'm like eating all these leafy greens now and I have increased dietary vitamin K, warfarin effectiveness goes down. So INR, I'm gonna have more chance for clotting, so it's going to decrease. Okay? Does that make sense?
Right, cool. Right.
So this is like a fun little game, so I just made. So EH was
Real story, by the
recent. Some
Not a-
parts of it, some
not
parts
a-
of it. The fact I have arthritis is real, but EH was recently placed on warfarin therapy following a recent diagnosis of DVT. She presents to your clinic for management of her dosing and counseling on her new medication. She's been taking oral contraceptives, which her physician is attributing as a causative factor for this new diagnosis. First, I want to stop. She's been taking oral contraceptives. Is this provoked or unprovoked DVT? Provoked. Okay. And what does that affect, like in the end?
How long?
Duration of therapy.
This would be what, 3 months?
Yeah, so if it's provoked, it's gonna be 3 months, and then if it's unprovoked and we don't know the cause, it's gonna be greater than.
Extended.
Exactly, I like it. Okay, so EH reports starting a new diet where she plans on eating more fruits and vegetables with lunches consisting of salads, fish, leans, proteins, stopping that fast food. But she loves spinach and Brussels sprouts. So we kind of already went over this a little bit, but it's kind of like a key word that we mentioned, like, am I just telling Emma to stop taking, like, just cut them out of your diet completely? You can never have these foods again. Moderation, like consistency, right? Consistency is key. If you're doing it, keep it the same throughout the week. Otherwise, there's gonna be fluctuations, right? We talked about how foods high in vitamin K impact INR, which was great. Now, okay, good.
Got it, thank you.
Now, she's taking NSAIDs. Will this affect her INR?
Absolutely.
Will it?
It won't, but it'll
increase your
affect
bleeding
her
risk.
bleeding.
Yes. Yes.
Yeah.
So remember, on one of your slides that you guys were given, it listed a bunch of medications where INR is increased, things like you know, halopurinol, steroids, like different antibiotics.
Next to it had increased bleeding risk.
Yep.
But it
Yes.
doesn't affect INR,
Yeah.
it just makes you bleed.
Exactly, exactly. So NSAIDs are one of those, don't get that confused. It doesn't affect INR, but we are still concerned because you have that increased bleeding
Are we
risk.
throwing aspirin on there? I know it's.
Yes,
Yeah.
it's different those antiplatelet.
Yeah. And then what's her goal?
Change the room.
Awesome.
That's the only thing I don't want to see. Sorry,
So now we're just gonna I'm gonna just lightly touch about the warfarin initiation and adjustment. So spend some time on this because this will be at least a few questions on the exam. I know that for a fact. I remember vividly on the exam that she will ask you questions on this. Okay, so Dr. Parsons loves asking questions about dosing. So know this by heart. Okay? No, listen, not only know the dosing, but know what caused you to change your dosing to go up or down. Okay? So when we're initiating a patient on warfarin, we usually do something called the heparin bridge. You guys go over that? Right? Heparin bridge. So you're gonna have an overlap between the heparin and the DOAC, right, before you get to your therapeutic window. So something about warfarin is that it's not something that works right away. Right? It takes a couple days for it to take full effect. So we're gonna have an overlap for at least 5 days, and you also need 2 therapeutic readings of the INR before you can stop the heparin. Okay? So remember that, right? So you need how many readings? 2. All right? And how far do they have to be spaced apart? At least 24 hours.
Oh, man.
Yeah, 24 hours.
Can I throw a question at you guys?
Yeah.
Okay, so if you have somebody and they're undergoing a procedure and they're on warfarin, how far ahead are we stopping that warfarin?
At least,
Oh, because of the half-life, yes.
5 days.
yeah. Right. Very good. All right, so when initiating warfarin, we typically initiate patients on either 5 or 2.5. All right, so 5 is gonna be for like our healthy patients or younger patients. 2.5 is mostly what we start like our elderly patients on. So if they're 65 plus, we typically start them on 2.5. Okay? So here's kind of like the chart that goes by, so like the different days that we go by. So, huh?
Do we get this
No.
on? We're gonna have to know this?
Know roughly what's going on. It's pretty much the same thing every time, right? So if we look for days 3 to 4, right, it's if the INR is less than 1.5, you increase the dose by 5 to 25%. I forgot what she says in class. She usually, I think she said a percentage. I think it was like 10%.
10%.
Yeah, 10%. Yeah, so you increase the dose by 10%.
And it's decreased as well.
Right.
Decreased.
Yeah, exactly. So you only make a 10% increase or decrease every time. And then if you go to days 5 through 7, it's literally the same exact change. It's the same thing. It's just that as you go on, those changes become a little bit more aggressive. So like here you see it's like 10 to 25, here it's 15 to 35. But just know 10%, it's not gonna differ on the exam, just know 10%. So if they're too low, you increase by 10%. And if their INR is too high, you decrease by 10%. Okay? Another thing that's important to know is knowing what changes your INR. Right? So like we talked about in the case, like if you get a case in the exam, they'll say, oh, your patient started eating leafy greens, or a patient stopped eating their leafy greens. It'll adjust the INR appropriately. It's gonna ask, what did the patient do to change their INR? It's gonna be their diet.
Stop being.
Right. Right. Okay, so also know like, oh, do we want to hold our dose or do we give like a booster dose? So sometimes if the INR is super high, right, we just hold the dose because we don't want them taking any if their INR is at like a 3 or a 3.5 or 4 or something like that, super high, just tell them to skip their dose. Okay. Right, warfarin question.
Still look familiar.
Yeah.
Hi, FB, how are you?
So
Welcome back, see you in a while.
he acknowledges some pain in his left calf. He's not sure if this is related to a previous injury or if it's something new. On his exam, his left calf is slightly pink with minor swelling compared to his right. FB described his INR 1.3 is likely because he missed the last 4 days of warfarin on vacation because he ran out of pills. So what is one thing about this patient that shows that this is kind of like a DVT situation?
It's like cast a slightly
Yeah, the
pink
one
with
side.
swelling.
Okay, so it's one-sided, yep, that's one thing. What else?
It's
It's
slightly
just-
pink
no,
with
it's,
minor swelling.
Slightly pink with minor swelling. Yeah, excellent, right? So those two things, unilateral, pink swelling. Here you go. So his INR is 1.3. So what's most likely causing that?
And this is
Is missing his dose, not being adherent. Very good. All right, and then what would you recommend for this patient?
go back to your regular like dosage.
Yeah.
Okay, yeah, very good. Yeah. Or we could even do a booster dose for this patient too, right? So a lot of times, I'm not sure like how in depth Dr. Parsons got into it, but like on one of my IPs, I went to a warfarin clinic. What you'll see is that like patients will get different warfarin doses, like they're not gonna be taking the same amount every day. So like one day they'll get 5 milligrams, the next day they'll get 2.5. Like some patients alternate, some patients take it Monday, Wednesday, Friday, it's different for every patient. So this is why like we don't like using warfarin, because it can be very confusing for patients to dose, right? Especially like sometimes when patients get a hang of their INR, like they even get like a machine to take at home, and they test their INR every day, and they can kind of like adjust their dosing at home. It's pretty cool, so it's interesting. All right, warfarin counseling. Okay, so we kind of covered a lot of these things, right? So know your indications for the warfarin, know about the INR monitoring, some adverse effects, and when to seek medical attention. So, right, if you see like any major bleeding, bruising, unresolved bleeding, any swelling, consistency, make sure you take it at the same time every day, and your diet, alcohol consumption as well.
If you have a case, like, take the whole case into consideration, like, even though we're talking about warfarin, there may be some like social history factors that they throw at you in a case where they're talking about alcohol consumption and smoking. Those things still play a role here, right? Like, especially if somebody's starting smoking or stopping smoking, that could be like a little detail in a case where, if they're asking, oh, what's something that we may be concerned about, look out for those little things. In terms of like social history, they like to throw things in there sometimes, especially because we know that like alcohol consumption, when it's like more chronic, we know that that can actually decrease INR, right? So all these little things that could play a role, just watch out for them in the case. These are our factor X inhibitors. So again, when we were talking about our different agents, we know that there's 3 main ones I think that you guys covered. So does anybody like remember name? I know they like to throw like brand generic names out here, or at least like the names of some of them. Pixaban.
Roxaban.
One more.
Redaxa is the brand name, but I cannot remember the generic, but I know it's Redaxa.
Edoxaban, yeah. So again, when you're going through these, just kind of use it systematically in terms of the case. Say, okay, do they have a DVT? We know that from, how they're presenting. Are they presenting, is it provoked or is it unprovoked? What are the patient factors? What is their kidney function? If we're using a certain dose, like I know for rivaroxaban, sometimes if you're using doses greater than 10 milligrams, it's recommended you take it out with food, right? So keep in mind that there are kind of little specific details that you may need to know specifically for this drug class. If it's something that is unique to that certain drug, I would suggest knowing it. I think that's good to keep it there. Especially like it mentions here, creatinine clearance cutoffs.
There will be creating first questions.
Yeah. Yes.
I don't know, it's their job, unfortunately.
So just like know, like generally which ones we're gonna be concerned about if they have low GFR, right? Because you may have a certain question and they're like, which one is preferred for this patient, but you look at their kidney function and they have so-and-so stage CKD and it's contraindicated.
Always Pixaban, that's like the safest way.
I believe so, yeah.
Usually, again, it depends on other patient factors, but usually. Okay. Unfractionated heparin. What's the difference between this and our low molecular weight heparin in terms of which ones they're inhibiting? Which factors they're inhibiting?
Unfractionated can inhibit more factors. I know that much.
Yes. Yes,
Yeah.
so,
Unfractionated can inhibit thrombin and and low molecular weight can't. But I can't
yes,
remember.
so the low molecular weight is just the factor X one. And then you're right, the unfractionated, we have the additional one with the thrombin that it can inhibit additionally, just throwing that out there. Again, knowing kind of the difference between these different dosings, I know that sometimes they will expect you to kind of know the differences between dosings based on if it's prophylaxis or if it's full anticoagulation. So you need to be able to look at a case and say, okay, I know whether I'm using this subcutaneous unit bolus that you're giving, or if you're doing the 80 units per kilogram bolus followed by the continuous infusion. So kind of knowing the difference on when you're using the weight-based versus not. And then remember, heparin is one that we are looking at APTT, right? This is, I feel like it's always like a matching, right, or something. And it's
Yeah,
like, which ones are we looking for APTT
Yeah.
in or something?
Yeah.
I felt like that was a
Yeah.
question, right?
So you're gonna get the chart, I believe, of like the APTT score, and it's gonna give you one, and you just have to adjust the doses. It's pretty much a free question because you get as long as you know how to use the chart, it should be free. So. Yeah.
And again, similarly, we have the dosing for this one. Again, just kind of pointing out here, anytime that you're going through these slides and you see that little creatinine clearance less than 30, just like highlight it, just mental note for it. Trying to figure out things specific.
Just know the difference between like, if they're getting like a knee replacement, it could be a different dose. I know, especially for the oral DOACs. Like for a knee replacement, it can be different dosing. For AFib, it's different dosing, stuff like that.
Something that I kind of just remembered, I feel like this was a question for us. I wouldn't get like too specific and like little like tiny details like this, but I remember how for like in terms of goals for your INR range, it was a little bit different for one of them. Do you remember? It's usually 2 to 3 for like most of them, and then one of them was listed 2.5.
Mechanical valve.
Yeah, the mechanical mitral valve specifically is 2.5 to 3.5. Like that's one that's just different, so just like keep that one in mind.
Yeah, if there's any information that's like outlier, they usually like to ask questions about that. So like black box warnings, things that's different like that, that's like stuff that they like to focus on.
You're gonna be better explaining this one.
So heparin-induced thrombocytopenia. So who can tell me what thrombocytopenia is?
That's a good question.
So this is like.
I'll get back to you.
This is when we have like a low level of thrombocytes in our blood, so your clotting factors just are plummeted in the tank. So we have like our reversal agents, I believe, and then there's different stuff as well. So we have for the management of heparin-induced thrombocytopenia. So we have the cessation of heparin and low molecular weight heparin. So as soon as you get those levels, you stop right away. You just stop it. So then we have non-heparin anticoagulation, because these patients still need anticoagulation, just that it has to be non-heparin. Okay, so the duration of anticoagulation is that we continue greater than 4 weeks in the absence of thrombosis, and 3 months with thrombosis. Okay, so in the future, if this patient has to get some anticoagulation therapy as well, can they use heparin or low molecular weight heparin if they have the HIT?
Yes, to heparin, no to low molecular weight.
Yes, so exactly, right, so they can use it, but they prefer to use a different agent, okay? Yeah, it's not, we would try to use something else first before we go to heparin. All right, so this is just like kind of what we were talking about before, so for the DVT, just the unilateralness, like swelling, redness, pain, warmth, warm to the touch. And then diagnosis, this is kind of like lab values that you see. So you have like the risk factors that you get from the patient's social history, the D-dimer, this is the ultrasonography, and then venography. So this requires contrast. And then do like a scan. This is actually pretty cool. So my brother, had a DVT from playing soccer. He, broke his foot and he got DVT. And,
Right there.
and he got an ultrasound. It's actually pretty cool to like see it like on the thing. And then the D-dimer level, that's like the lab value that you see for, stuff. So which way, so when we're talking about D-dimer, is it elevated or decreased? That's gonna be the, sign of DVT.
It's interesting.
Is
I'm
it?
not sure.
If it's a fibrin degradation product, I would assume it's decreased. No.
Oh, it's increased, yeah.
So, or,
Jacob gaslit us
Am
for
I-
a minute.
like, I don't remember this part of the lecture.
Yeah, it's,
So you have to find the get an idea. That's the reason why they do the test.
It's literally up there, guys.
I'm reading it, I'm just curious if I'm reading it correctly.
yes, yeah, so
Yeah.
it's always elevated with BT.
Okay.
It is kind of like counterintuitive to how you would normally think about it, but kind of keep in mind that it's not something that's like specific to this like condition, you would say. It's not specific.
All right, so VTE treatment, so of course, there's different drugs that we use, in patients with cancer and without cancer. So VTE treatment without cancer, you have your DOACs, so you have your dabigatran, rivaroxaban, apixaban, or endoxifen recommended over VKA, and who can tell me what VKA is? Warfarin, yeah. Okay, good. There's a special counseling plan about the dabigatran. Who can tell me what it is? If you go on, if your rotations, I know for a fact the pharmacist is gonna ask you if you go on your community rotation. Huh? Yeah, so you keep it in the stock container, yeah. Yeah, so do not open this container. Another thing is, if you work retail or if you're going on a rotation retail, if you ever fill a drug for HIV, always keep it in the original container as well. Don't open it. Keep it in the original container. Because, don't ask me why, I just know.
We'll find out.
Don't ask me why, I just know.
We'll come in here.
So for the VTE treatment with cancer, we have our oral factor 10 inhibitors. So that's the apixaban, endoxifen, and rivaroxaban. So which drug are we missing here? Nope. We don't have the bigger.
Oh, well, what are we missing? I thought you said which one are we
Right.
using?
We're missing the bigger, right? And those are recommended over low molecular weight heparin and PKA. So previously the low molecular weight was the standard of care, but it has a higher risk of GI bleeds. And then we also have a GI bleed risk with endoxifen and rivaroxaban versus the low molecular weight, especially with patients with GI cancer. So the low molecular weight has a higher risk compared to the other two. Okay.
Give me Eliquis all day.
Huh?
I said, give me Eliquis all day.
Yeah, exactly. Easy, right? So apixaban or low molecular weight can be preferred in patients with GI. So these are the special pops for VTE. So patients with antiphospholipid antibody syndrome, so they prefer the VKA over DOACs. In pregnancy, low molecular weight is a standard of care since it doesn't cross the placenta. And then pediatrics, those suggested low molecular weight, warfarin, dabigatran, or rivaroxaban as preferred options. And then stuff with pediatrics is kind of like touchy because like you can kind of use everything, but they're not really studied because it's not really ethical to study drugs in kids, unfortunately.
One thing that I do kind of want to make note, because I remember this being an exam question. For apixaban, there's a specific dose adjustment that was mentioned, I know, like briefly on one of your slides, and it has to do with non-valvular AFib dose adjustments for apixaban. And there's kind of like 3 different criteria that were talked about, where you're decreasing the dose to like 2.5 milligrams twice a day instead of whatever that usual starting dose is if you're meeting like 2 of a certain criteria. Do you remember what those criteria are? Because I remember, at least for us, it was like a multi-select.
Oh gosh.
Yeah, I don't remember anything, so.
Yeah.
To be fair, we did this one was recorded.
Yeah.
We didn't get to ask
We
questions.
listen to you guys, actually.
Yeah, we listened to you all, that's
Oh.
fine.
First one is age.
I actually heard you two specifically
Yes.
in a recording multiple times.
That's who I keep hearing.
How does that happen?
First one's age, over the age of 80. Second one has to do with body weight. Less than or equal to 60 kilograms, or, so it's or for all of these. Or serum creatinine that's above 1.5. So if you're hitting 2 of these, then you're using the alternate dosing. I know that's listed on your slides, but just, it's something that's like one line I remember, and I kind of skipped past it, so just like look at it, because I remember it being a question.
So you throw the three, right?
2 out of 3, yeah.
You guys know what the factor is to go from pounds to kilograms?
What?
How do you go from pounds to kilograms?
Yeah.
Yeah.
What are we doing once?
Hey, whoa. All right.
We need you to reel it.
All right, so pulmonary embolisms. Okay, so clinical presentation. So it's often clinically silent, right? So it's kind of like the way I remember, I think it was Dr. Hong who was explaining it. He's like, it's like an instant killer. So you'll be talking to somebody and then they'll just like drop dead because they'll go to their lungs, drop dead. So potential symptoms that they can have as it's like developing is dyspnea or tachypnea, chest pain or tightness, tachycardia, hemoptysis. Who knows what that is?
Killing of hemoglobin?
No. Is it? I think so. No. Or is it coughing up blood?
I think it's coughing up blood.
Yeah. Is it coughing up blood? Okay, let me just make sure, but I'm pretty sure it's coughing up blood.
I'm pretty sure it's coughing up blood.
Good old Google.
I know, right?
Yeah,
For the
Google.
terms,
Coughing
like,
up
you know
blood.
what?
Yes, it's coughing up blood. Oh, okay, all right, good. Okay, see, cardiovascular collapse, and then death possible within minutes, right? So like I explained, just you'll be talking to somebody and then that's it, they're done. Right, so then we have the shortness of breath or increased breathing rate. So for treatment, we have our parenteral anticoagulation. So we have the unfractured heparin. So IV heparin is like the preferred agent if it's acute, right? So if we have that patient that like they just dropped dead, we're gonna just try to give them IV heparin as fast as we can. And then we have our low molecular weight and then fundaxiparin. And then you can transition to warfarin, right? So we're gonna have that 5-day period that we had, and you need therapeutic INR 2 times separated by at least 24 hours. For our DOACs, we have rivaroxaban and apixaban we can use. We can start that immediately. And then we can also use the Vigatran or endoxiban, but you need 5 to 10 days of parental bursts. So yeah, you'll use those usually. There'll be more apixaban or rivaroxaban. And that's pretty much chosen just based on what's covered on the insurance, unfortunately.
And unfortunately, like a lot of the stuff with anticoagulation is just being able to like pinpoint what you're using when, dosing when, which is a lot of like memorization, fortunately.
Yeah.
But that's what it comes down to.
Yeah.
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 Not doing that.
You gotta, you gotta know if anything's in.
And then it'll be gone.
Yeah.
Use it.
Okay. All right, on to any questions on the anticoagulation, like any stuff that you guys want to talk about? Anything in the chat from you guys? You guys can unmute to ask questions.
Can we talk about, when we're gonna give oral vitamin K or like the consent?
Oh, okay, Central, yeah.
She like barely went over it.
Yeah.
Using in the slides.
I mean,
So for that, I would just know what the reversal agents are. I wouldn't necessarily know, like, I wouldn't bother knowing like when to use them, just know what they are.
no, the like just what the name.
Yeah.
But.
Yeah, K-Central vitamin K, right? So if you overdose on warfarin, what are you gonna do? Are you gonna do K-Central or vitamin K?
If you're overdose on
If you're overdose.
it, you're not do both.
Yes, you do. So you're right. So you can,
Yes.
you can use either or, right? So if you're overdosing on warfarin, you're inhibiting vitamin K, so you're going to be at increased bleeding risk, right? So you want to increase vitamin K, and then K Central is like the blood factors that have, you're basically replacing the blood factors, right? Because the way that warfarin works is that it binds to like that enzyme and like irreversibly inhibits it. So you have to wait for your body to make new ones. So instead of waiting for your body to make new ones, you just give your body new ones. Yeah.
Also knowing the reversals from the side ends.
Yeah, the factor 10 inhibitors, no, the reversal agents for those two.
Thank you.
Anything else for you guys? Any other questions?
Think of anything.
Yeah, feel free to ask at any time. All right, moving on to heart failure. So two kinds of heart failure, right? We have HFpEF, heart failure preserved ejection fraction, and then HFrEF, heart failure reduced ejection fraction. Where HFpEF is 50 to 70, and then HFrEF is less than or equal to 40. And HFpEF is due to diastolic function, and what's diastole? Is that contraction or relaxation? Yep, and then HFrEF is due to systole. So know how to calculate the ejection fraction, right? So stroke volume or end diastolic volume times 100. That's gonna be a question. I can hear two. One question. It'll be one question, but it'll be on there. All right. And then major causes of heart failure: hypertension, coronary artery disease, and heart attack. All right. So heart attack. How does heart attack cause heart failure?
Because the tissue stops being able to function properly.
Yeah, so you're gonna kill the tissue and then your heart goes under like reconstruction, and it's just not as good as it was before the heart attack.
And then can't build back.
And remember, there's kind of like the in-between, so you have HFrEF, HFpEF, and then they kind of talk a little bit about like the mildly reduced and like the improved ones. Yeah. So do you guys remember the range for that one in terms of like percentage wise? It wasn't on Hom's slides, I think.
41 to 49.
Yeah, 41 to 49. That's just good for out there.
Hufflepuff, that's what we're calling it.
Right.
Calling it Hufflepuff.
Right.
Got it.
So this is kind of like what we were talking about before. So, right, so we have chronic stress on the heart. It's going to cause hypertrophy. So there's going to be concentric and eccentric hypertrophy, and that's just going based on what the left ventricle is doing, right? So concentric, you're kind of constricting the volume that the left ventricle can hold. The eccentric is expanding that thing, right? So the way that I think about it is when you say eccentric, your mouth like goes wide. So eccentric, that.
Dr. Harmful.
Huh?
That's what Dr. Harmful.
Yeah, I mean, it works. Yeah, it works, right? So you're gonna have chronic high preload and eccentric, right? So your volume's always gonna be high. You're gonna have a thin wall, larger chamber. So if you have a thin wall, what is that going to do to contractility? It's going to decrease, right? So you're not going to have enough muscle there. It's not going to. Something that's actually really cool is that runners have a hypertrophic heart. So like when runners are like younger, it's good, but then as they get older, they can kind of like run into heart issues, which is pretty cool. It's cool to know. It's pretty cool. Yeah. So right, remember, so this concentric is caused by hypertension and high afterload. So why would that cause? Who can tell me what afterload is?
Pressure needed to pump. Pressure needed to be overcome. Oh my God.
Yeah. Right, so
There's blood that's pressuring it,
yeah.
and you need to overcome it.
Right. So the left ventricle pushes the blood out of the heart and into the body. So the afterload is the amount of like it's the pressure from the blood that's pushing back on the aortic valve. Right. So you have to overcome that. So hypertension is going to increase that afterload, and you have to overcome that. So if you're trying to overcome that, the heart's going to undergo hypertrophy to get more contractility, right, to be stronger, so it can go against that pressure. All right. So here's this chart over here. So hypertension to heart failure. So you're gonna chronic hypertension has afterload. So we see this concentric reconstruction over here. Sorry, so you have a decreased chamber diameter, increased wall thickness and stiffening, decreased blood filling, and diastolic dysfunction. This is going to increase O2 demand. This is going to increase your risk of ischemia, increase myocyte death, and fibrosis, right? Right, and eventually leading to heart failure. So there's two types of heart failure. There's left-sided heart failure and right-sided heart failure. Cool thing to know is that right-sided heart failure is caused by left-sided heart failure. Yes. And their effects are going to be different on the body. Right, so we already talked about the left-sided heart failure. So you have HFrEF and HFpEF. And then what are some symptoms of HF or of left-sided heart failure?
Pulmonary edema.
Very good, right? So if you can't get blood out of the heart on the left side, it's going to back up into the lungs. You're going to get pulmonary edema.
With those people, you may also like see those common things like cough, you know. But if it's more right-sided, that's where you start to get like your effects in other areas of the body, right? If there's a question and it's like, in which type of heart failure are we most likely to see like enlarged liver, right? It's not the lungs, it's someplace else. So that would be something where we would say it's right-sided. So even if they throw something like really weird at you, think, okay, it's not the lungs, it's somewhere else in the body, or it's fluid buildup somewhere else in the body, like peripherally, then we know that it's not the left one.
Right, here. And then that's like we see like the edema, and like I was mentioning the enlarged liver. And then you'll have like the hepatojugular reflux.
JVD.
JVD.
Yeah.
That's right. Yeah. So what's really cool, I don't know if you guys learned about it in self-care, because I don't know if just get taught by Dr. Pasha or Dr. Gonzani.
Oh.
Oh, so
Mostly Dr.
so even if a patient's like normally healthy, if they lay down on the table, if you push on their liver, they'll get like the JVD. It's cool.
Yeah, we did.
Oh yeah, the skills, yeah. Cool. All right, so O2 demand, kind of like what we were talking about before, right? So if we're increasing our heart rate, increasing contractility, and if there's more wall stress, you're going to increase O2 demand. And if you're not getting enough oxygen to the cardiac muscle, it's going to die. It's not ideal, very bad. So, and then here's just a couple of pieces of information about the wall stress. Know this formula? Know that formula?
They're not gonna have to like calculate anything with it, but like know
Like what?
Know
So
how they relate.
know how the radius and the wall thickness affect the wall stress, for sure. Just know the formula itself. Let me see if there's anything else that we should cover. I think that's it. Yeah, just know like the different shape. Okay, then just like how we were talking about before, so left-sided heart failure, signs and symptoms, you have fatigue, shortness of breath, sweating, tachycardia, and then like most, the cough is also
the
getting.
liver. They like to throw the liver in there for some reason.
Yeah,
So
hepatomegaly, enlarged liver. With the right-sided, right, you have peripheral edema, jugular vein distension, ascites, hepatomegaly, and then right upper quadrant discomfort. All right, so just kind of think of it as anything before the heart, it's right-sided. If it's anything in the middle of the heart, right, so like in the middle of the process, so in your lungs, it's.
they love to ask this question.
Yeah, you're gonna have like a couple questions like this. All right, compensatory mechanisms, right? So this is your body's response to the heart failure that's going on, right? So it's going to increase the heart rate, increase your contractility, and increase your blood volume as well, right? So that's like, so your thing right here, right? So if you have the increased pressure, it's going to increase the flow, or it's going to increase resistance. Let's try to combat that. So if we increase blood volume, it's good because you increase preload, right? So you're going to get more oxygenated blood out to the body. But in the long term, increased preload will lead to pulmonary congestion. It's going to lead to increased afterload, which is not good. Same thing with heart rate, right? So you're going to increase your cardiac output, but it's bad in the long term because it leads to less filling, increased metabolic demand, so O2 demand, which will lead to ischemia and myocyte death and fibrosis. Right? So fibrosis happens when those myocytes start dying. They turn into fibrotic tissue because cardiac tissue can't get replaced easily. And then adrenergic stimulation, right? So this is the increase of activity in the sympathetic nervous system. It's going to increase your heart rate, which increases cardiac output, which is okay, but in the long term, it decreases the cardiac beta receptors, which decreases sensitivity and contractility, which is no good. And then all in all, in the end, it just all results in maladaptive structure changes and decreased cardiac performance.
So before you continue, I know the rest of the slides that are on here are still like things that are important for Dr. Hong's lecture. When I was going over the cahoots, a lot of the cahoots are covering like the exact same material in here. So we can still, it's up to you guys, because I know it's like 5, we have the room until 6, so we will stay here as long as you guys need. But do you want us to go through that portion, or would you rather like test it in the Kahoot, because it's gonna be like very similar material? Or do you guys not have a preference? We could still go over it and then do the Kahoot, or whatever you guys want to do.
I'd go back to what you guys study too.
Do you want to start the Kahoot then?
I don't think, yeah, you
Because
want
yeah, a lot of
You
the
guys-
guys, yeah, we want you guys to sing too,
Okay.
like, no one's here to do your own side.
Oh, is it? Okay.
Yeah,
Yes,
but there's like a question on each one of these.
oh, cool. Yeah, okay, yeah, that stuff's like, yeah, I just,
Like Doyle Campbell on like the heart failure today.
Yeah.
So-
Yeah, we did, we just went over all of
Okay.
this. The 4 pillar, we went
yeah,
over.
just know, I just wanna cover, so like, just know the 4 pillars, right, beta blocker, ARNI, MRA, SGLT2. That's it, yeah, that's it. Cool. Let's get the cookie going up. Let me, plug my computers.
Oh, yeah. It may be like a similar to Kahoot to something that you guys have already seen before, I'm not sure. You guys got the same exact one in class, but we can like go over and talk about the answers, so that you guys understand it.
I should have Drew Campbell just thinking we're all just giving up.
Alex, how do I switch to the?
Imagine like one of your coworkers seeing your sister going, I thought it was you. And I'm like, you know I'm in Massachusetts. Like, what is wrong with you? One of our pods is broken. One of our pigs is.
The bottom one, say,
Yeah. So my coworker texted me.
Any questions?
And then he's like, I'm pretty sure I have.
Honestly, you could be a professor.
Yeah, you. Honestly, I was showing more today than like overall.
I was
Have you thought about going into architecture?
fellowship,
Capachas?
I did break it, but you know, you can only do like one,
residency, academic residency.
Yeah, you could do capachas or
What's that on the radar?
I never got that feedback before.
You like, yeah, you guys are good teachers. Well, Jacob, I don't know, but. That's what you get for shining a laser at me today.
Oh yeah, and I didn't get to like explain this, I kind of just wrote it and then left because he was talking, but like, this is important to know for like the future, because these terms constantly pop up. Just like if you see something that ends in that, that means that there's typically a deficiency, so like thrombocytopenia is low platelets. And then if you see something like leukocytosis, that typically means that those levels are elevated way beyond what's normal. Especially now in psych, it's like,
Also, it's good on like rotations too, like if you see, like inpatient, sometimes if you go on rounds, sometimes you can observe, like they'll be saying stuff, so it's like, we don't know exactly what it is, you can kind of follow around sometimes.
Are you having Dr. Doyle Campbell's cuckoo?
I stalk her Kahoot. I go through all.
You ever-
I had no idea it was until she, like, I kept looking it up and I'm like, I can't find her cahoots, guys. No one told me.
Yeah, there's no more that amounts.
don't do the IPC assessment, just start with like the 10 question, yeah.
You want my credit?
I was looking at
There are.
Oh, wait, that's so cute.
Like, I wanna do that with a
Yeah.
family game night with some wine and.
Wait, we could do that.
Oh my god, we could do that. That would be mad fun.
Yo,
At a party.
Yes.
Or at a arcade friends, we should.
Yes.
We should do.
We all have to
Cookies or
send in
PowerPoints.
baby photos, but like one of us can't play because one of us has to bake it.
Can we also do like PowerPoint presentations?
Yeah,
On,
no,
like random topics.
PowerPoint night.
So I can't see the rest of the code.
Hyperfixation PowerPoint. You take
Thank
your
you,
one
Jacob.
hyperfixation topic and.
Wait, we should do that.
Fun names, come on, make me laugh.
Oh, fuck. Well, give me a minute.
It's okay, there's like another one, this one's like short, they're like only like a couple things.
So I actually trying to skate with the problem, like,
Thank you.
oh.
Be good, be good. Wow. Want to ask?
I don't know, is that you?
No, it's.
Evil Alex, as opposed from good Alex, okay.
How many people are in Zoom? Emily's on Zoom.
Emily.
I miss you guys.
No, you do, no, do Bridgeport, CG, all right, mine.
How do I want to go get the?
The Marriott.
I was just.
Yeah, that's my computer.
No, this is Emma's computer first.
I wanna go get the.
It says Emma Hall.
Thank you.
In fact, you move my computer. Or I move my computer. I'm losing.
Marriott, Bridgeport, Connecticut.
What?
Like some lore behind the computer.
Marriott in Bridgeport,
Connecticut.
Connecticut.
I don't even.
Why would I wanna go to
It's
the?
freaking real.
Why would I wanna go to the Best
Oh,
Western?
that's good. I never said.
Oh, the Marriott.
Oh, the Marriott. Oh, Kaylee's on there too.
Hey, we saved up, we got you a little vacation, all expenses paid.
Yeah, Kaylee's on there.
We're
Okay.
sending you to the Marriott.
There she is.
Oh, I'm still alive.
Yeah.
Okay, where's the camera?
Oh, that's perfect.
It's like up here. It follows you, like if they walk up there, it follows you.
Alright, Lionel has HEPREF, no symptoms, with an EF of 32, what stage does he have?
I know.
Since you can't see it, no symptoms, EF of 32, if you didn't see it.
You had a perfect leaderboard.
Please, no, I'm gonna mess it up, I feel like I messed it up.
Come on.
I guess up until 25 seconds and I'll.
Is the timer someone?
Alright.
Okay, let's talk about it. So, stage one. The main things here is that our patient has no symptoms, right? So for the New York stages, that would be stage one, no symptoms. The rest of them goes from mild, moderate, severe on.
Class A means they don't have heart failure yet.
There's nothing, and no NYHA goes in class A.
They got that ejection fraction of 32%, so we're concerned, so it wouldn't be class A.
They definitely got heart failure.
Which
Thomas.
heart failure did they have? What flavor?
HEPREF.
Yes.
Yes.
It said that. Jacob, I didn't know this.
One of my.
Let's go ahead.
I love that you guys are together.
I know, that was-
Beautiful.
perfect.
Lionel has HEPREF, no symptoms with an EF, what medication should be started on? 2-day
This is a pillar's question.
fillers.
Mhm.
Imagine if I get them wrong and we just.
Yeah.
I'm so scared I'm gonna get
Did you
them.
guys just do this one?
Yeah, we did.
We did yesterday too.
It's no one day though.
Yeah. It's okay, we got this.
It's a good refresher, you know?
Yeah.
Yeah.
If we forget, it's whatever.
We have an excuse. There's like a little self-care review.
Yes.
Very good.
Oh, we have to.
What's, I
Yes. So what would be like not a contraindication necessarily, but what would be something of concern No,
Bridgeport, Connecticut's on top. Sorry. Sorry.
So if we're gonna start in Arnie, what medications are we, there's two classes of medication we're looking out for in the patient that they're already on. Yeah, ACE inhibitor, what's the other one? ARB, right? So we wanna make sure we stop the ACE or ARB before we start the Arnie, right? What are the two medications in Entresto? So Cubitril, yeah, so what is that? Valsartan, right? Very good. So we have the ARB in there, and then we have the neprilysin inhibitor. There you go. So he's having symptoms daily, consider right-sided heart failure. Which symptoms are most likely? So right-sided heart failure.
Oh no, dude. The Marriott Inn is about to go down.
No, not the Marriott Inn.
Let's go, guys.
Very good. Yes, everybody's got it. All right, good.
I'm just making.
Another test taking strategy is look at answers that are similar, right? So if there's answers that are similar,
Different question.
probably you can toss off, right? So here we have rails and shortness of breath. Those will have to do with the lungs. Probably not what it is. Okay.
Sorry.
I know.
Be faster, maybe.
Marriott.
Which medication is contraindicated in heart failure due to SNS activation?
Oh my god, wait, this one scared me because I thought I misheard it, but no, I'm right.
Nice.
So amphetamine salts, right? So that's Adderall, right? That's gonna increase.
Considering earlier, like half of us put for Apamil, so this is pretty good.
Not Strattera.
Yeah, you know?
It's not Strattera.
It is not Strattera.
Oh, you're.
But I'm pretty sure Strattera is
Way.
contraindicated.
Oh, man, Ally looks so
Yeah, I would.
Oh, it's so cute.
All right, which medication is a positive inotrope?
Who wants to explain what a positive inotrope is?
It's increased contractility. I know the Digoxin song by heart. I know it.
I love it.
What?
Is that in the song?
Yes.
All right, DAPA is approved for heart failure in what patients?
Oh, is that the song she posted? Is that the video from you? Wait, no, she posted the boyfriend rap. That was funny.
Yeah. No, this is
I
from
love
a
the
nurse. I think it's
Robin.
Nurse Mike. It's to the song. It's like a parody of the song Down, but it's about Digoxin. And it's used for nursing students.
Yeah, I believe that like Napa and Emperor are the ones that you can
I'm
use for
obsessed.
like anybody.
Yeah.
And then Invokana is the one that there's kind of a little bit more research that if you have somebody with diabetes, that it can have slightly more benefit. So that's where this question's
So
coming
you'll
from.
almost never see Invokana.
Yeah, exactly. So.
And then
I'm obsessed.
blue.
Oh, Thomas.
Oh, no.
Yeah. Our Mary has Hepareth, no meds, and has 5 pounds of fluid. What should be started? What kind of diuretics do we use in heart failure?
You did.
My bad. The Marriott.
Yeah, very good.
Just-
Right, so we want to use loop diuretics.
did.
Right,
Drop the song.
loop diuretics.
Thomas.
Thomas, you're messing this up.
Goodbye.
Haley, can you be a little slower?
Here we go, Hepareth, 5 pounds of fluid. What should not be started today?
That one was quick.
I did a little slow, you know?
So then I probably just passed you because I was on it.
That's all.
Hey, we care more about the order. Well, that we finish. Okay.
I care more about winning.
Well, we're trying to make a joke.
Right, so like kind of like this one, so think about it. All those other drugs are gonna decrease the fluid in the body. Right, so furosemide is a loop diuretic, EMPA is SGLT2 that increases diuresis, and then valsartan also increases diuresis. That's when you trust them.
This is like one of the ones that was listed as like a major contraindication, right? If you have like any type of evidence of fluid retention, then we're staying away from the beta blockers to start. Additionally, if you have somebody and they're like hypotensive, right? Are we gonna like and they have like bradycardia, are we gonna put them on something that's gonna lower that even further? No. So like when you're doing a case, like I always even look at like blood pressure and heart rate sometimes because that's just something so easy to overlook, but like it's it's something that pertains to a lot of these medications, so. What happened, Bridgeport, Connecticut? What happened?
I was trying to make it so it like it's actually doing
I'm getting the break.
I'm behind Emily. She's just me.
Hey, Emily over Zoom, can you just?
Emily made a mistake. Can't you hear us?
What plans Jackson
What's behind you? I promise you, it's not, I don't care about order, I don't care about word place.
I'm never on the podium.
I just need to.
Let's go, Vivi, you got this.
Last question, which medications are the best options for patients with F?
That took me too long, I think I lost it.
I can't remember.
Well,
Wait.
Wait,
Wait, I got rid of Emily.
Oh my god, this is the new.
All right. Marriott.
Emily texted.
We're just gonna cover this right here.
Oh,
Bridgeport, Connecticut.
Hey, I was born there, okay? We did that right.
Marriott.
East side.
You guys wanna do another one?
Okay, yeah, we do have other one. I don't know if you guys just did those two.
We just did this
We
one.
just did this one.
Oh, okay.
I wish I was able to take a picture.
Right, try out.
Don't have the kind of Doritos.
She's not gonna leave it. Emily, what kind of Doritos are you eating?
Type in the
Wait, guys,
chat.
can you hear me? I'm eating purple Doritos.
If I need it, maybe.
If you can hear me. What?
That's so she better. She's stretching too hard to hear me. Wait, she texted us.
I can tell Jacob to turn up the volume.
I couldn't see it. Just tell Jacob to turn up the volume. What?
She can't hear.
Wait, what does that have to do with?
I don't think she can hear us. Wait.
I'm like, there's so many cameras going
I don't know
on.
what she's
Can
talking
you hear?
Emily, type if you can hear. I'm confused.
Who put the code in?
Okay, do not tell this.
That's me.
Jacob, is it a natural blonde or is it?
Wait,
I
Emily's calling.
dyed my hair. I'm actually a redhead. Alright, let's get started.
Oh, that's what you meant.
Say the word starting, get your food.
Right, medication.
Wait, I'm gonna have to close, so I have to put you on speaker.
I'm kind of Doritos.
So we couldn't hear Emily because your volume was down is what she was getting at.
Oh, gotcha.
Wait, I can't see the question.
Oh.
No. That's
Emily,
fair.
what kind of Doritos?
Nice.
Oh, that's it.
Okay, so yeah, remember that for this one, this is like a major like counseling point for this one. That they have to, you have to stop it like 36 hours before. Yeah. Good guys.
Would I see it?
Oh, yeah.
Which lab?
This is like back to renal, guys. This is what this is reminding me of,
No,
right?
no, I hit the wrong one, I hit the wrong one.
It still applies here.
No, I hit the wrong one, I didn't see the second one. That's so mean, why would you do that?
Okay, why?
Because it's elevated
Yeah.
and it's K sparing.
What's the normal level?
5 to 4 point.
So 3.5.
Oh.
Yeah.
Oh, that's where I go.
Is eating?
Which is the best beta blocker for
Oh my gosh.
asthma?
Oh, God.
That one.
It's on your phone.
It's obviously the overdose that person just had, like,
Yeah.
Jesus,
Yeah.
take a
So
breath.
why is bisoprolol the best?
It's more selective.
Very good, right? So we want to use this, a non-selective beta blocker in somebody with asthma. It's gonna activate what receptors?
The beta two.
Beta two, very good.
And we wouldn't use the total heart rate
Oh,
in
no.
someone with heparin.
And we wouldn't use a
Or heart failure
atenolol at all.
We use succinate.
Great.
You know why?
I don't remember.
I just know they're not the same.
Well, succinate is extended release, but,
Good boy.
oh, thanks.
Oh,
I should do this shit.
This is how our classes are constantly.
That's not bad.
So in the middle of class, we just start going, Thomas, good boy.
Please don't. I'm good. That's why I named myself Jacob's Blonde.
I earned that right. So Cubitril increases which peptide?
We did do this one, we did.
Aldose.
I forgot it.
How did I take so long to answer that? I went ahead. I'm so close.
Who is conjugated for Entresto?
Obviously, it's not this.
Very good, right? So angioedema with lisinopril.
That's crazy.
Which
Not making this mistake.
That's Mr. F.
No, yes.
Yes.
I'm the one.
It's all good.
We remember it.
It's 41 to 29.
Oh, Any questions about that one?
Jacob
It's
is
just-
blonde.
I don't know if
Jacob
it's
is blonde. Good.
Yay.
Jacob is blonde.
So we're done. She's like, I lost him done. Hey, you're gonna get the
Hey, you know what? All the people in person were on the podium and in top five.
Yep.
That's what I'm talking about. Guys. Good.
It's like.
We got more.
This is the last one.
Okay.
I know the preform's having candy right now downstairs. So I just want the candy.
Swing by.
Yeah.
On the way.
Well, apparently Econ brought candy today and I went to go use the bathroom and no one saved me yet.
I didn't realize you
I-
left it behind you.
I left it out.
It got taken and was not there when I,
It's
Not
not
there.
my fault.
8, 9.
it got taken and like I wasn't offered any.
I'm sorry, Katie. We did try. I didn't know we were gone.
We'll just do this one and then if you guys don't have any questions, I don't know, like, you guys do one.
Okay, yes, I do want candy, thank you.
Really?
44, that's me. Get some cold cuts. Get some cold cuts. Number 44, that's me.
Where's Trevor's
You don't know
Are
that.
you chronically online?
No, that's a fucking, that's a Geico commercial
Yeah.
from like a decade ago.
I've never heard
Get some
that.
cold cuts.
Oh,
That's so niche, though.
Is that you, Ian? What?
No, baby, please,
No, I'm
Haley.
just. Oh.
Cardiac output is heart rate times.
You should have this like ingrained in your mind.
Oh, yeah, 100%.
Yeah.
Come here, Steve, come here, Steve.
Oh no, I'm behind.
Don't say it like that.
Stroke volume divided by EDV is what?
You're missing something.
Yeah, it needs a little something, something.
X 100.
We'll blame that on the fact that it doesn't say times 100.
Yeah.
You're right,
Yeah.
you're right. You're not Dr. Han.
We are what?
We are Dr. Han.
Yeah.
Oh, wrong.
Fuck.
No!
I did not.
Okay, so why is it aldosterone? Tell me why. So what does-
Thomas, you knew
what does
it.
Aldosterone do?
No, I got it wrong. What are you talking?
I got it right, but I guessed between the two.
I got it wrong.
So why?
So aldosterone does what?
Increases blood pressure?
How? So RAS,
Renin?
right? Renin-angiotensin
Yeah.
aldosterone system. So it causes the retention of sodium, which causes what? The retention of water, right? So it increases your blood pressure through the retention of fluids.
Okay.
Yeah,
Right, so if stroke volume decreases, that means that our blood volume is low. Right?
indeed.
Right.
Indeed.
What?
No.
Like that.
Yes, baby.
This was the
The
one.
ventricle is stretched.
I hit the wrong thing, I hit the wrong thing. No,
Oh my god, that's wrong too.
I hit the wrong thing.
Okay, good.
Right, so this is, so when someone's having a heart attack, we test for this, right? We test for that.
I hit more heavy by mistake.
Good, it brought me up.
Beta blocker, ADE increases with increased lipophilicity.
Yeah, you're absolutely right.
Yo mama.
Joseph Mothers?
TE, very good.
What? Who said that? Who said that?
I'm never gonna get that.
What beta blocker would have most effect on blood pressure?
Oh dear. Man babes?
There's two man babes in there.
No. I have it.
Three man babes.
Isn't that like your thing, it's man babes?
That'd be the one.
No, it's, oh yeah, because they're cute, yeah.
No.
Whatever, I gave up anyway. It was the wrong answer.
Nice. Nice.
Who's Flower?
Your mom.
Please be.
She is a flower, thank you very much. She's a beautiful
I
flower.
always say that to my dad.
Alright.
Katie wants candy.
Thank you so much.
Alright,
Thank
you
you,
guys have any
guys.
other questions? If anything else comes up, feel free to reach out, okay?
Oh,
Our charge
Don't worry.
this question's hard.
you're reaching out.
Yeah. I feel like her questions.
They're fair.
Really, they're pretty fair.
Okay.
There's no the dosing and
She
no
does like a ring. She does.
Oh,
multiple choice. Sometimes she'll do like a, I don't know if there's short answer.
she never does short answer or multiple choice. Or like multi-slice, sorry. No, multi-slice. Yeah.
All her questions are pretty fair.
Multi-select.
You guys will be fine. If you have any questions, let us know. Enjoy your
Yeah, you
candy.
can-
Go get candy, Katie.
If they don't have it, I'm actually gonna be so upset.
She's coming back in person.
I'm coming back and during her hour, and I'm just gonna come take you so fast.
Thank you.
The secretary of employee is a how can you do that?
Yeah, it's Matt, dude.
Yeah, how can you do that?
Probably because.
Probably because they're best friend.
Yeah,
Yeah.
yeah, I don't know. But yeah, he emailed me or texted me last night. He's one of my advisees, like, hey, how do I email everybody?
Yeah, he emailed all of us to come to this.